Well, I'm Carly Tomczyk. I'm a nurse practitioner at the Pediatric Center at the University of Minnesota. And my co-chair, Dr. Juliana Bailey, is a registered dietitian and instructor at the University of Alabama at Birmingham. In our session today, we are, with the changing landscape of nutrition care in CF, The landscape of nutrition care in CF is rapidly changing in the setting of highly effective modulator therapy. This session will highlight abstracts that address shifts in nutrition status that are occurring in the CF population, strategies to assess and address nutrition status beyond BMI, and nutrition care in CF as it evolves with improvements in care and extended longevity. This is a joint session between the nursing and dietitian nutrition disciplines, so you'll be seeing both points of view here. The first speaker that we have is Dr. Larson Odie, who is a clinical professor of pediatric endocrinology at the University of Iowa. Her research interests is in the pathophysiology of cystic fibrosis-related diabetes. Clinically, she cares for both adults and children with cystic fibrosis-related diabetes.
And of course I'm shorter, so I have to bring the thing down. Okay. And then I got to get my presentation up. Ooh. Okay. Whoops. This button. Okay. There we go. Okay, so I'm very honored to be asked to speak today, and thank you for the wonderful introduction. On this slide, I just want to point out I'm actually presenting on behalf of one of my colleagues, Dr. Granados. She was unable to attend, so this is actually her project. I am part of the team, but this was her project, so I just wanted to honor the fact that this is her hard work. So I do have a relevant disclosure. Once upon a time, I was invited to be on an expert panel with Vertex, and I am going to be talking about their medications. So this would be considered a relevant disclosure. Okay, so we all know why we're all at this session, and that is because of these absolutely fantastic drugs that have been life-changing for our patients, which include elexacaftor, tezcaftor, ivacaftor, or as I will call it for the rest of the presentation, ETI. And of course, these medications really improve the lung function for our patients. They reduce pulmonary exacerbations, and they make our patients much healthier. And this has really changed so much of our landscape, and we have done a really good job investigating the pulmonary effects of these drugs, but a lot of other things are less well understood. And historically, as probably the vast majority of the people in this audience know, BMI was a predictor of long-term outcomes in that a higher BMI was better. People with low BMI or people with declining BMI had increasing risks of death prior to the advent of our highly effective medications. However, and I feel like every time I talk now, I'm like, historically and now. And so since we've had these wonderful medications, all of us have noticed clinically that we are seeing a lot of weight gain in our patients, and in some of our patients, really dramatic weight gain, including obesity and overweight. And so I think a lot of this session, really, this is what we're all going to talk about today. And so the point of this particular presentation is we're going to look at body composition. And so we know our patients have increasing BMI and increasing weight. There isn't a lot of data yet on body composition. So, whoops, helps if I push the right button. Okay. There we go. So in this particular group, the objectives of this project that were put together was to look at body composition from DEXA. There's a lot of different ways you can measure body composition, but that's what we decided to use in our study. And of course, as mentioned, I am a diabetes pathophysiology person. So this study was also looking at OGTT-derived indexes of insulin secretion and insulin sensitivity. And we were looking at people before and after initiation of ETI therapy. And so this was kind of a convenient study. So we have a very large project that I'm doing with Dr. Chan, who's in the audience, Dr. Granados, and Dr. Amir Mohit, who's at Minnesota. And our large project is intensive phenotyping of glycemic status of a group a goal of 475 individual tests on patients, and that study is still ongoing. So this project was sort of we are doing a sub-study in that larger group looking at changes in body composition with the thought process from Dr. Granados that we would see different fat-free mass versus muscle mass in people based on their glucose levels and their insulin secretion. And so in our larger study, we have a sub-study where we've been getting body composition by DEXA. And what we realized, because our study initiated basically right before ETI came out, was that people were going to start ETI clinically while they were in our study. And in the background large study, we are getting people can be in the study in a prospective basis, and they can have testing done every year. So we realized we had a chunk of people probably that had intensive OGTT testing and a DEXA scan for body composition both before and after they started ETI. So we decided to pull out that data and see what we got. And so our background study recruits people from 6 years and up to infinite age, potentially. And for this group of people, we pulled out our people who had an ETI initiation, and then from that group, we picked out the people who had a DEXA and an OGTT available before and after they started ETI. And the measurements that we had on our DEXA for body composition, and I keep pushing the wrong button, were fat-free mass adjusted for height, which is going to be listed as fat-free mass index going forward, and then fat mass adjusted for height, which will be listed as FMI or fat mass index. And the glucose phenotyping is a frequently sampled oral glucose tolerance test with time points taken at 0, 10, 30, 60, 90, and 120 minutes. And we did 3-hour studies, but in this group, a huge chunk of these people, for some reason, we didn't have the 150 and 180, so we only analyzed 0 through 120 minutes for this particular study. The things that we assayed were glucose, insulin, C-peptide, and we used the area under the curve. And then we used a couple of indexes. We used an index for early C-peptide secretion because the first kind of abnormality you find in people with CF is abnormalities in early insulin and early C-peptide secretion. So we looked at that. And we were also wondering if there was going to be a change in insulin resistance. So we used an index. The HOMA2IR is an index that looks at insulin resistance based on C-peptide levels. And then we didn't do lung function testing as part of our study, but we pulled their lung function information from their chart review. So this is the group. So this is a small study. We had 8 subjects. And you can see, although our overall study had a big age range, this particular group of people were pretty tightly in age, which is probably helpful given this is a small study. So they were mostly teenagers and young adults. For some reason, our overall study has a pretty good sex ratio, but for our patients who we managed to get a visit before and after ETI, they were overwhelmingly male for reasons I don't have any idea why. But so that is a weakness of this study, is that we have an overwhelmingly male sample. We do have a nice balance of people who were homozygous and heterozygous for delta F508, which is nice. And then you can see we have most of the subjects in this particular trial had been on ETI about 12 months when they had their almost a year when they had their second visit. And all these subjects are pancreatic insufficient, which is nice because otherwise that would be a bad confounder probably. So, and then you can see their baseline weight and then their weight Z-score. So at baseline, the majority of them were just a little bit underweight for age. And their BMI was also a little bit low for age. And they had pretty good lung function. So this is probably the most important data from our study. Let's see if my little boxes will show up. Yes, cool. And so you can see, as probably everybody in this room is used to, our patients gain weight. And of course, some of them are growing. So the weight Z-score is going to be more probably statistically relevant than their actual weight gain. But you can see their weight Z-score also increased. And instead of being on average slightly underweight for age, they're now on average normal weight for age. And then their BMI Z-score, whoops, for some reason I didn't highlight that. Their BMI Z-score didn't change, although you can see statistically, significantly, but you can see it did not statistically, it looks like it's higher. And then the most important thing, which was the whole kind of point of this study, is the body composition. So as you can notice on here, so the fat-free mass index is everything that's not fat. So that's your organs, your bones, and your muscle mass, although it's generally speaking a good measure of muscle mass. And usually when we look at it, we think of it as being a measure of muscle mass because usually your organ volume doesn't change rapidly, and your bone density, although it does change in CF patients, doesn't change this measure much. And so the fat-free mass index did not significantly improve, and you can tell even given this is a small sample, that isn't very big change in that. And then the fat mass index, however, increased significantly, so that's about, on average, 2 kilos of fat mass increase, and that was statistically significant. So that's probably the most important kind of takeaway from this very small study is that we did get a statistically significant signal. And in a group of 8 people, that's pretty impressive, I would say, because it's not a very big study. And we wouldn't have a lot of power. So that's really the primary finding of this study, is that the weight gain was pretty much, at least based on our analysis, mostly fat mass and not muscle mass gain. These are the diabetes endpoints that we looked at. And like pretty much everything else that we see with Alex-Tez-Iba, there was no change in our measure of glycemia. So the glucose area under the curve did not change, did not get better, did not get worse. And the oral deposition index is a measure of the ability of kind of to take up sugar. So that's kind of measuring a little bit more intensively, but a similar thing. And then similarly to other studies that have looked at ETI, we saw a slight improvement in early insulin markers. So this is looking at C-peptide rather than insulin itself, but these are markers of early insulin secretion. And you can see that it did improve slightly, although the glucose status didn't change. And the other thing that I want to point out, which we don't have a ton of data on in other studies yet, is that our measure that we used for insulin resistance also increased. So basically, this is a very small study, so this data needs to be taken carefully, given that this is only 8 subjects. But what we found here is that they gained weight, like we all expected them to do, and that weight gain was primarily fat mass. And then, like other studies have found, we found a small increase in estimates of insulin secretion, but also there was increased insulin resistance and no change in glucose values. And so, of course, the primary takeaway from this study is we need to keep looking at this. We need more information. But this is very, I think, useful from a small study perspective in that it's showing that kind of what we're all afraid of is true, is that they are probably gaining fat mass rather than lean muscle mass. So, and that's all my slides, so I'm happy to take questions.
We have a couple questions that came in on the app here, and if you have questions, please send them through on the app because we don't have microphones and this session's being recorded, so we need to do them through the app. The first question is, when you looked at fat mass and fat-free mass, did you look at total body less head data or all data including the head?
We did do total body less head. That's a wonderful question. Somebody in the audience knows their DEXA stuff.
Okay, our next question is, did you assess physical activity habits at all?
No. And so that's part of the problem with this being kind of a sample drawn from a larger study that had a different objective, right? So we're not collecting physical activity as part of our study. And of course, this happened during COVID. So my guess is their physical activity did not increase. It probably worsened because the initial ones would have been like before COVID, and a lot of the other ones are as COVID is starting, or at least some of them are. So my guess is their physical activity, if I was just going to guess, we didn't measure it all, but if I was going to guess, if anything, it probably got worse. I don't know what you think, Christine, but that's probably true, right? So like, there's no way it got better. So I mean, yeah, so that's a good question. Would physical activity improve this? My answer would be, I have no idea. A really smart CFPT or somebody should really look into that sort of thing. That'd be a great study for somebody to do. To see it, but you would assume it would, although sometimes things are not, you never know until you check. I wouldn't guarantee it, but you'd assume increased physical activity would help, and we don't have that data on this study.
Another question, why do you think insulin resistance increases?
Oh, well, if your fat mass increases, your insulin resistance increases. So, these patients are getting more healthy. So it's actually, I said that silly, but it's a good question because we know that their inflammation decreases, and inflammation is an incredibly strong driver of insulin resistance. So it could have easily gone the other way, right? Our patients are less sick, they're less inflamed. The thing is, though, if you increase your fat mass and not your lean mass, you are going to increase your insulin resistance. Now, this study needs to be taken with a grain of salt for that insulin resistance marker because it's a very small study, right? And that is that particular calculation it's not like the best way to, there's much better ways to measure insulin resistance than that measure, but it's a good measure, but there are clamp methods and stuff that really will tell you truly how insulin resistant somebody is and where it's coming from. And what we know about insulin resistance in people with CF, it's a little bit complicated. So historically, people with CF tended to be peripherally insulin sensitive and then insulin resistant at the liver. But insulin resistance always has increased with age in people with CF, so they tended to be historically very, very insulin sensitive, like more than you would expect. And they would become insulin resistant when they got sick, and they also had increasing insulin resistance with age. And so when you're looking at insulin resistance, and we don't have any control samples here, so I can't tell you that they're more insulin resistant than what a control would be. They're just more insulin resistant than they were, if that makes any sense. So, but it is an increasing problem in our patients with CF, and it didn't used to be. And we have actually sort of an expert in that sitting right there. Dr. Litvin knows more about this than I do. Sorry, I'm embarrassing her, but she deserves it, because she's really good at it.
So how did the fat mass pre and post ETI compare with standard recommendations for a healthy fat mass percentage in these age ranges?
I don't actually know. I should have looked at that. My guess is that, well, no. So some of the patients went from too little to fine, and some of the patients went from fine to too much. I can tell you that. That's all I can tell you. So some of our patients had too little fat mass. So for some people needed to gain fat mass, and some of our patients didn't need to gain fat mass. And not everybody gained fat mass.
So another question we had was along the same lines of physical activity, but we were wondering if anyone looked at diet in this population.
No, that wasn't an endpoint they were collecting. I think Dr. Chan is sorry now, but we weren't collecting it. But no, it's hard. It's really hard. So the underlying study is the goal is 475 subject visits. When you get diet records on that many people, it's really challenging to parse it, especially since diet records are very, very inaccurate, as probably people in the audience know much better than I do. So I was teasing Dr. Chang because we talked about it, but it's just very, very hard to parse the data. I have gotten it on other trials that I have done and been unable to make anything with it. Because diet recall is inaccurate, and it's very hard to time it to when the abnormalities are, and a lot of people don't fill stuff out. So we thought about it, but in a really, really big study, it just becomes in kind of unmanageable reams of data. So it would be nice to have, but it's very challenging to do in practice, and we needed to get this study. It needed to be something we could actually pull off. So it would be nice to have in the context of the body composition, and it would have been nice to have in a context of a couple other things that we're looking at too. So.
Another good question we had was, given the change in fat mass, is the trajectory of increasing fat mass a problem, even if it was in a malnourished patient who is going to having a more normal fat mass?
I love this question so much. So the thing about fat mass increase is that this is what you'd expect to see in somebody who is malnourished. If you had somebody who was sick and they weren't gaining weight because they're sick, what we know from the literature is that they do put on fat mass before they put on muscle mass. So this could just be an illness recovery phenotype, even in our people who had too much fat mass before, because they were sick and they got better. So this could be an illness recovery. So it's possible that if you follow, and I had great questions about this when I was standing by my poster, it's very possible that if we continue to follow these subjects, their fat-free mass will start to rise, and then they will go in a pair. Because whenever you gain weight, you always gain both muscle and fat, and when you lose weight, you lose both muscle and fat. Like, we don't like that, but that's the truth. And so it's very possible that if we continue to follow these, the body composition over time, that we'll start to see an increment in fat-free mass, because you expect the fat mass to increment first, and this is only about 11 months of follow-up on these subjects, so it's possible that in 24 months or farther out than that, they will have a matching increase in their lean mass, especially if their physical activity picks up. So it's possible we're just seeing an illness recovery phenotype, or we could just be making everybody fat. That's a good question. Like, that's part of what we don't know. So, but that's a really good question, because probably at least some of these people, this is good fat, and probably some of them it's not. We probably have a lot of subgroups. And in a small study, you can't tease that out, which is why we need more people to look at this.
And then along those lines, from your perspective, when is the fat gain considered too much?
Me personally, so so that's a good question. So I don't think we know. The thing about, and other people are going to talk about this extensively after me, but the way we measure whether people have too much fat is extremely crude. It works very well at a population level, like when you're looking at hundreds and hundreds of people, but people are very individual, and we're learning a lot of. One of the best examples of this is when you're looking at what we used to call female athlete triad, which now has another name that I can't remember right now. But if you're trying to figure out if a woman doesn't have enough fat mass, the best way is when she stops mensing. And there's people who will stop mensing at a BMI of 75%. That means she doesn't have enough fat mass. She might have way more fat mass than, and I have patients who have a BMI that is very low, who mense regularly every month, no problem, everything's completely normal. So she has enough fat mass for her, and then you'll have people, and she'll have a BMI of 19. And then you'll have somebody with a BMI in the 75th percentile, and they'll drop from 80 to 75, and they'll quit mensing. So those two women have very different normal fat mass amounts, right? And this is true for our CF patients too, because I think a lot of the weight gain that we see in our CF patients, if you want my personal opinion, not based on data, just based on my personal experience as a CF practitioner, I think a decent chunk of my patients who have gained so much weight are just norming to where their BMI always would have been if they've never had CF. So there are some people who have an unbelievably terrible diet, and now they're not sick and catabolic. They are getting heavy because they have a terrible diet, and they were really sick and catabolic, and that was kind of keeping them skinny in a very unhealthy way. And now they have a terrible diet and they're not terribly sick, so they gain weight like crazy. But there's definitely a chunk of people who are just renorming to, they were supposed to be an 85th percentile BMI person. They were on the 50th and now they're on the 85th, and we're like, that's bad, but that might be normal for them. So, part of this whole wonderful session is talking about how do we figure out what's right on a more fine basis, as opposed to these crude tools that we typically use. So, great questions. I'm getting such good questions. This is awesome.
Thank you so much, Dr. Larson-Odie. That was an excellent presentation. Thanks
You're welcome.
for highlighting
Thank
all
you.
the nuance involved.
All right, our next speaker is Kanan Patel, who is a registered dietitian and has worked for the last 15 years as part of the cystic fibrosis team at Children's Healthcare of Atlanta and Emory University CF Center. Kanan values the importance of education in the field of CF nutrition and has been a member of the CF Mentor Program for Nutrition. She has been a promoter of quality improvement initiatives at her center and is currently involved in 2 QI projects, improving vitamin D testing and sufficiency, as well as improving oral glucose tolerance test completion. Her interest in research and QI has led her to publish and present abstracts at poster sessions at NACFC on topics such as the use of appetite stimulants in CF, building blocks of CF class, improving vitamin D, effective modulators on nutrition, and utilization of the HealthWell Foundation grant.
All right, another shorty over here. So, deep breaths, right? I just click on this? Ah, thank you. Okay, and oop. Okay, so thank you, NACFC, Juliana, and Carly, for giving me this wonderful opportunity to share my work. Body mass index versus mid-upper arm circumference. Everybody's been to the nutrition session. It's the hot topic of the day. Can we replace the BMI? Well, let's find out. I have no relationships to disclose related to this presentation. So why have we used the BMI like a gold standard in CF? I've been a dietitian for 21 years, and for the last 15 years, I've been working with CF, and at my first conference back in 2007, I learned that many dietitians had already moved away from standard method then, the ideal body weight, and started using body mass index because stature, being tall or short, led to inaccuracies when using ideal body weight. And then the official guidelines for BMI came from the CF Foundation in 2008. Now we'll talk about BMI and MUAC in a little bit, but BMI has been used as a measure to predict nutrition status in general population for decades. But in CF particularly, because optimal BMI correlated to better lung function, it has been the standard of nutrition assessment in people with cystic fibrosis. Now, since 2008, based on this particular BMI and FEV1 graph, this is from 2016, I have been telling all my patients and parents, I'm sure so have you, that we need to work towards a better BMI or achieving the 50th percentile BMI, because better the BMI, better the lung function. If BMI decreases, lung function will likely decrease. Showing this graph whenever possible, if you have a BMI of 5th percentile, you're likely to have a lung function of 60th percentile. But if you achieve 50th percentile BMI, that could mean almost normal lung function. But where are we now? Now, as we look at this 2020 graph, it doesn't tell us the same story. Now, a BMI of 5th percentile could still mean a lung function of 75th to 80th percentile, a big change. And a BMI of 25th percentile correlating to normal lung function of 90th percentile or higher. And I know, we're all thinking, wow, modulators, right? And to be honest, how amazing is it to be at this session at NACFC called Health is More Than a Number, when for 15 years we have focused on one number, 50th percentile BMI. So and I know in the previous nutrition session we learned a little bit more about the history of BMI, but a little bit more for those who don't know, that did you know that it was created by a Belgian mathematician and statistician, Adolphe Quetelet? Not a physician and definitely not a dietitian. He created this in 1832 as the Quetelet Index, and the scale was created using data predominantly from European men to measure weight in different populations. And although he noted that it was a population-level tool and not meant to be used on individuals, it was used to measure obesity in individuals. And then later, a physiologist named Ansel Keys reintroduced this calculation in 1972 as the body mass index. And it has since been adopted by the medical community as a way to measure individual health. So why use BMI? Or why have we used BMI? It is simple to calculate in a clinical setting using just a scale and a stadiometer, which most of the clinics have. One can easily track changes over time. It allows us to classify over and undernourished. But the downside is that it does not account for fat mass versus lean mass, nor does it account for placement of fat mass on the body, and it does not account for waist circumference or total body water. As you can see in this picture, a clearly more muscular person can have the same BMI as an obese person. leading to the misclassification of healthy or unhealthy. Now, mid upper arm circumference has been used since the late 1950s, a lot more in other parts of the world than in US. But Dr. Jelliffe and the Caribbean Food and Nutrition Institute team used it to detect acute malnutrition. It is considered to be surrogate measure of fat-free mass. In 2017, the MUAC Z-scores, or the measurements from 2 months to 18.5 years, were published, enabling diagnosis and classification of malnutrition possible just by using a single data point of arm anthropometry. And by late 2010s, Dr. Abdul Rahman at Mercy Children's developed this new color-coded MUAC tape with scores and malnutrition zones. How many of you are actually using mid-upper arm circumference in your clinics? Okay, a decent number. It's pretty good. But for those who don't know, MUAC is a measurement of the left or non-dominant upper arm's circumference halfway between the tip of the shoulder, acromion process, and the tip of the elbow, the olecranon process. And the arm needs to be bent at the elbow at 90 degrees. Make sure it's relaxed and make sure that your young patient is not flexing it. So MUAC is pretty simple and quick. We can train community workers or parents to use it. It is inexpensive, portable. It is a good indicator of acute malnutrition, and unlike weight, MUAC is not affected by fluid status or hydration status, which may be good in a situation where weight and BMI aren't reliable measure or markers of nutrition status. But MUAC can be less sensitive with extreme Z-scores, and it is not widely studied in US, specifically in specific disease states. So this brings us to our little study. As Dr. Larson mentioned earlier, obesity is on the rise in people with CF, and we wanted to look at a better predictor of nutrition status in our pediatric population. MUAC has been studied to predict fat mass and measure pediatric nutrition status and assess for malnutrition. So in 2021, we added MUAC as part of our nutrition assessment method at our center. The purpose of our study was to compare BMI and MUAC and just see how they are used in our particular clinic setting and compared in our CF children. Our study was IRB approved. We performed retrospective analysis on 87 patients. The mean age was approximately 10.7 at the initial visit and approximately 12 years at the subsequent visit. We collected data on BMI, MUAC, FEV1 from April 2021 to March of 2022. We divided the Z-scores into nutritional zones, zone 1 being well-nourished, zone 2 being mildly malnourished, zone 3 moderately malnourished, and zone 4 severely. We looked at the correlation between BMI Z-scores and MUAC Z-scores, as well as MUAC Z-scores and FEV1 and BMI Z-scores and FEV1. We obtained subsequent measurements in 34 patients. Sorry. Our mean FEV1 was approximately 96% at the initial visit and 99% at the subsequent visit. Okay. Our results indicated that BMI and MUAC Z-scores had a statistically significant linear correlation. At initial visit, 86% of the patients were identified as well-nourished when we used BMI, and 74% of the patients as well-nourished when we used MUAC. But if we looked at it from the malnutrition lens, then 14% of the patients were identified as malnourished via BMI, versus almost double, 26% of our patient population was identified as malnourished when used MUAC, indicating MUAC identified more patients as malnourished than BMI. Even in the well-nourished group identified BMI, of the 75 participants, 11 of the patients were identified as malnourished from looking at the MUAC, about 15%. And then an interesting observation that we made post-study, that if we use the Z-score of 1 as the cutoff of overnourished for both BMI and MUAC, that 19.5% of our patients were identified as overnourished via BMI, but only 8% were identified as overnourished when looking at MUAC. It kind of goes along with the whole how we identified more patients as malnourished. We did notice that patients who improved their MUAC between visits had an improvement in FEV1, and we had hoped to find a correlation between FEV1 and MUAC as we've seen historically with BMI and FEV1. But FEV1 correlation was not statistically significant for BMI or MUAC Z-scores in the well-developed and well-nourished group or in the malnourished groups in our study population. The statisticians noticed that of the 3 values, if the patients had a good FEV1 at the previous visit, they had a better FEV1 at the following visit. Bringing us back to that 2020 BMI and FEV1 graph that we looked at and the change in relationship between BMI and FEV1. Another interesting observation that we also made was that 63% of our study subjects were on a modulator when we did this retrospective review. And of these modulator patients, 47% were on Trikafta, which may explain our patient mean FEV1 above 95% at the initial and the subsequent visit. So in summary, based on our study and our results supported the previous research, yes, malnutrition and MUAC, being that MUAC is more sensitive to identifying malnutrition when compared to BMI. However, we're not sure if it's due to small sample size, retrospective nature of our review, use of modulators, possible intra or inter-provider measurement variability on why we can't establish a correlation between FEV1 and MUAC. But just like BMI and FEV1, we need larger, prospective, multi-center study on MUAC as a nutrition assessment method in people with CF to determine such correlation. We also need to look at the impact of modulators and revisit BMI and FEV1 correlation. Many of us have already been questioning this, and it's been the topic this weekend, but we probably need to further question whether increased BMI really means improved health. And especially in the era of highly effective modulator therapy, look at the improvement of FEV1 regardless of BMI, and possibly uncouple the two. Of course, we want all our children and people with CF adequately nourished, but really focusing on what well-nourished means in terms of lean mass and fat mass, and looking at other nutrition methods such as DEXA, BIA, MRI, CT, BOD-POD, and ultrasound that are more sensitive in differentiating fat mass versus lean mass. So I think the question kind of changes from where I started, and it's not can we replace BMI? It's should we replace BMI? And the answer, I think, seems like a hard yes. So that's my project. I want to thank my wonderful team who helped me collect this data last year. So Megan, Malia, and Dinisha, and Christine, thank you so much. And then I also want to give shout out to my team who's here to support me today. Thank you.
Thank you for that wonderful presentation.
Thank
It was
you.
very interesting. So we have sort of a comment and a question. I've noticed that many of my patients have lean arms but extra abdominal adipose tissue. Is there a way to identify these patients in your studies? Would they have been considered malnourished via the middle upper arm circumference? And clinically, would they be malnourished if they have this excess central adiposity?
And so that's a wonderful question. And I specifically remember this one patient who had a BMI in the normal range. And then when I did his mid upper arm circumference, like 3 consecutive visits, I noticed that it would consider him as malnourished. And obviously, don't have the data of the waist circumference. I did not measure that, so I cannot compare that now. But I think we need multiple data points to really say that if one measure says that this person is malnourished, I think we still have to look at the whole picture. And I think kind of goes back to how BMI, we're looking at this one thing, but we really need to look at probably multiple points on that particular patient to determine that.
Absolutely. So given your findings, what would be your stance about BMI versus MUAC in clinic?
So BMI, I mean, and I feel like, 15 years ago, if you had asked me this question, I would have said, well, BMI correlates to FEV1. It means better lung function. Like, this is what we know. But now in this HEMT era, we can probably look at, again, going back to the whole picture, looking at the whole patient, and not really just BMI and not really just MUAC. I think we have to kind of look at both things. I have started to, in my particular clinic, in the last couple of years, asking patients, to even if they really want to see the growth chart, because I don't know if we're really creating a healthy mind setting by using BMI, because ever since we've started using the modulators, because the numbers are climbing. And so maybe MUAC would be more sensitive to our patient's mindset, but I think we have to look at the whole picture.
That's a great answer. And then I have a question personally. What are your future directions given your findings in this work?
So what I would love to do would be to work with a lot more dietitians from different centers, because I think the data is in numbers. If we can collaborate together with multiple centers and say, okay, we all get the same education on how to measure MUAC, and so kind of 4 or 5 dietitians measure the same person over and over again to see if we're getting the same result. And once we kind of achieve that, less variability, combining multiple center data to see if there is more to it. That's what I would like to do.
I think that would be amazing. We have just a couple more minutes for questions if anyone else wants to drop a question into our app.
There was one that came in about, what about MUAC on adult CF patients?
So my love is peds. I've only done peds my 21 years of career, so I don't know, but if there are any adult dietitians here that are doing it on their patients, I encourage you to answer this question. No? Okay.
Thank you so much for your talk.
Thank you again.
Okay, our next presenter is Megan Coons. She is a clinical dietitian for the Cystic Fibrosis Center at Children's Hospital of Colorado. She has worked in the pediatric pulmonary nutrition for 11 years, and she specialized in CF nutrition for the past 4 years. Prior to that, she worked in pediatric oncology and hematology at Cincinnati Children's, and we are excited for her to talk to us about a caregiver perception of lifestyle and education tool. Welcome, Megan.
Okay, welcome. So yeah, we're going to talk about an educational tool that we created to try to prevent some overweight status in our younger kids. And I have no disclosures. So a little bit about our background, which we already know that ETI is a CF modulator, and it's now approved for for children's age 6 and up. In clinical trials, we know that this has an increase in BMI, and at our CF center, we have a pretty large, the biggest pediatric population, and we did see that rapid weight gain in some of our adolescent and teenage patients. And after we saw that increase, and we knew Trikafta was coming for our younger population, our team really wanted to think about how can we be more proactive with this next group that's starting on Trikafta. And we really wanted to make sure that all the patients were getting standardized education and all the providers were having those conversations with our families. And so the quality or the objective of our QI project was to really educate those families on what clinical changes they might be expecting to see upon starting Trikafta. We wanted to talk about the possibility of needing less calories. We wanted to promote healthier eating. We want to encourage physical activity and emotional well-being, and eventually try to prevent that rapid weight gain. And in this population, since birth, they have been told high calories, high calories, high calories. And we know it's just such a change in the mental thinking of these parents of doing something different than what they've been told their whole life. And just by chance, as we started this project, the CF Virtual Improvement Program, or their VIP program, was being offered. And so our team applied for this program and we were accepted. And it's a 12-month virtual program that consisted of 3 working sessions and 2 progress report sessions. And this was just a really nice program to work through our project. So if anybody out there is thinking of doing a QI project and you want a little bit more support, this is a good option to work through your project. So as part of our QI project, we developed a multidisciplinary team of social work, psychology, physical therapy, our providers, and nutrition. And then we also had some parent partner with us to develop a proactive educational tool. And then several months after starting ETI in this younger population, we sent a survey through our Epic MyChart system to the parents, asking them to fill out a survey to get some feedback. And the survey assessed their perception on the educational tool and then also looked at some behavior changes following initiation of Trikafta. This is our cute little card, which I do have copies of it if anybody wants to grab one afterwards. But it went through just very basic information, but good talking points of what is Trikafta, what medical symptoms or improvements might you see, what are some nutrition changes that we might be making, some exercise recommendations, and then mentally just how to kind of be aware of that you might see some changes. So when we looked at our survey, there were multiple answers that they can answer. I didn't have room to put all those questions or the options, but we'll go through the questions real quick. So we wanted to know if they first remembered if they remember receiving this card from our center. We wanted to know what lifestyle nutrition changes they made. We wanted to know what dietary changes they made. We asked about which following items they worried about, how they wanted to receive future education, and then any behavior changes that they've noticed. And actually, when we did this was a little bit before we heard about some of the more mental psychology changes. And so we sent out 54 surveys, and we had about 37 respond, so about 75% responded to our surveys. Out of the 37, 28 remembered receiving the tool and found it helpful. 2 did not find it helpful, and 7 did not remember receiving it. Maybe somebody else was with them in clinic, I don't know. And then the lifestyle and nutrition changes that they reported making were increasing fat at breakfast. So we all know we encourage taking a little extra fat with Trikafta. And so breakfast always, from what I see, is the hardest meal to try to get in for our kids. And so just trying to get that fat in was important. So it's good to see some made that change. And then switching the Trikafta dose from a bedtime snack to dinner so they didn't have to get extra fat late at night. And then increasing activity levels. A couple other health changes were choosing healthier snacks, stopping oral supplements, and switching to lower fat milk. I was a little surprised that only 3 people reported stopping oral supplements, because I feel like in clinical practice we have been a lot more aggressive and have cut back or decreased that with our families. And then some improvements since starting ETI included eating more food at meal times, less stomach aches, being more active, having bigger snacks, and sleeping better. And I think that is a great thing in this younger population, because there's a lot of picky kids, a lot of kids who just struggle with eating, and knowing that Trikafta is an option that can help improve those meal times and eating behaviors is a nice benefit. We did ask, too, what their concerns were, not related to nutrition, but just overall with Trikafta. And potential side effects was definitely the most common concern: insurance coverage, and then lack of improvement with treatment. And then we were curious if they preferred an electronic educational tool or in-person physical tool, and 2/3 requested future educational material to be provided electronically. And we do have this as a PDF, so we can send it through my chart to our families too. So after our education, we were curious to see if it helped keep our BMIs and growth in a little bit normal range. So we compared BMIs before Trikafta and then a year after starting Trikafta, and then we compared it to our patients who did not qualify or did not want to start on Trikafta. And really what we saw was no significant change in that increase in BMI. And I would be curious to see what other centers are seeing, because we just haven't seen that rapid increase in weight gain in our younger population. So in conclusion, this tool, it was well received by our families, and it aided in our medical team discussing when starting ETI. And the majority of caregivers reported dietary or lifestyle changes after being on ETI therapy, including improvement in eating, activity, and sleeping. And then we did see that minimal change in our weight gain for our younger population. I think that's it.
Megan, that was a wonderful presentation, and I love your tool. I'm definitely going to be taking one of those. Do you have any plans for how to expand this work or expand it to an adult population?
We only have pediatrics at our center, so if any adults want to know about this, they're welcome to take it and adapt it. We do in Colorado have a pretty active population too, and very healthy, focused population. So our families are usually pretty interested when we're talking about being healthier and being more active.
That's awesome. And could you speak a little bit more about your survey development when you surveyed the patients and families?
Yeah. Well, we were kind of curious, since we were sending it out, that we did want to know what changes they were making with their eating, and then it was just beneficial, since we had them doing the survey, just to look at the other concerns that they had outside of just nutrition.
I love how patient-centered and patient-focused it was. We did get a question, with switching the ETI to dinner, was there difficulty in keeping the AM and PM doses 12 hours apart as recommended, or was that less of a concern?
At our center, our providers haven't been too strict on keeping that exact 12 hours. They've focused more on just an AM and PM dose and getting those doses in. And so they were okay with doing a dinner dose versus a snack dose.
I think that's a really great strategy, and I've heard that other people are using that in clinical practice as well. I'm on the adult side, so it's cool to hear about it going on in pediatrics. Carly, are you seeing any?
I am not seeing any.
Okay, well, keep putting your questions in. We should have some time at the end of the session to give more questions to all the speakers. And thank you again, Megan. That was a wonderful presentation. So our next speaker is Krithika Sundaram. She's a fourth-year medical student at Northeastern Ohio Medical University. And during her time in medical school, she's conducted research regarding cystic fibrosis at Rainbow Babies and Children's Hospital, and she'll be discussing her work with us today. Welcome, Krithika.
Hi, everyone. Thank you for the introduction, and thank you for allowing me to present today. I have no disclosures. So today I'm going to be talking about a study we conducted about a year ago regarding the impact of CFTR modulator therapy on nutritional status, hepatic steatosis, and dyslipidemia. And I conducted this study with Dr. McBennett, Dr. Flask, and my mentor, Dr. Cutney. So I know we've been talking a lot about the background of cystic fibrosis and BMI. So historically, cystic fibrosis was characterized by malnourishment. Lots of patients were having lower body mass index, producing worse lung function, and having early mortality. And this is when the high-calorie, high-fat legacy diet was introduced. This diet consisted about 30 to 40% of calories from fat and 110 to 200% of RDA caloric intake. And it was shown that patients with higher BMI were having better pulmonary outcomes and increased ppFEV1. So a lot of this diet was recommended to many patients for several decades. Now we're fast forwarding to today, where we're seeing a growing number of people with cystic fibrosis that are now overweight and obese. Specifically, 26.7% of adults with CF are overweight, and 10.3% of adults with CF are obese. So now looking at these graphs from the 2020 CF Foundation Registry Report, on your left you can see this graph graphing the median nutritional outcomes for individuals 2 to 19 years from 2000 to 2020. And you're looking at the percentiles of BMI, height, and weight, and you can see that there's been a steady increase from 2000 to 2020, with about a 20 percentile increase from 2000 to 2020. And the CF Foundation recommended for this age group, for people under age 21, to have a BMI that should be at or above the 50th percentile in the CDC growth chart. And you can see that we are well above that in 2020 today. And then looking at the graph on the right, you're looking at the median BMI values for adults 20 years and older for 2000 and 2020, and you're looking at the BMI increase in men and women. For men, you can see that the BMI in 2000 was about 21.5 and is now increased in 2020 to about 23. And then in women, it's about around 21, increasing to 23. And then for this age group, the CF Foundation recommended that the woman maintain a BMI of at least 22 and men a BMI of at least 23. And you can see that's slightly above the recommendation today. So now we're looking at CFTR modulators that were introduced in the more recent years, a novel class of medications that restore CFTR function. Ivacaftor was approved in 2012 for gating mutations and is highly effective at restoring CFTR function. Then you had Lumacaftor, Ivacaftor, and Tezacaftor, Ivacaftor, which are CFTR modulators that were introduced between 2015 and 2018 and provide modest improvement in CFTR function. And then finally, Elezacaftor, Tezacaftor, Ivacaftor, which I'll refer to ETI for the rest of the presentation. That was approved in 2019 and was highly effective at restoring CFTR function. So with the addition of these modulators, people were starting to think if it's immensely improving lung function, how it can affect the other parts of cystic fibrosis-related disease, specifically looking at the GI tract and seeing if you can naturally gain weight. So there were many studies that were conducted that looked into modulator therapy leading to weight gain. This first study conducted by Volkova looked at disease progression in patients with cystic fibrosis treated with Ivacaftor in both the national UK and US registries. I've included the US numbers here, and they saw a mean BMI increase of plus 1.3 compared to those with Ivacaftor compared to those who didn't have it with only plus 0.7. And more recently, the study published in WashU that looked at 134 adults with CF and found that the use of ETI was associated with an average of 4.43 kilograms per year of additional body weight. This study also found impact in serum lipids as well, specifically looking at an increase in total cholesterol, LDL, and HDL before and after modulator treatment in subjects with cystic fibrosis-related disease. So then we also start to look at consequences regarding weight gain, specifically higher body weight associated with insulin resistance. So specifically, the Bone-Hur study looked at 290 adult subjects and looked at cardiometabolic risk factors and lung function. and were shown that even with a better FEV1 and higher BMI, there was association with insulin resistance. We also, when reviewing literature, we're looking at hepatic steatosis as well. So in 2018, Ayub conducted this retrospective cohort study and found that being overweight and having a higher ppFEV1 were significantly associated with hepatic steatosis, suggesting some overnourishment occurring in the population with that high-fat, high-legacy diet that was being practiced. However, this study found no significant association with hepatic steatosis and modulator status. And then more recently in 2019, a cross-sectional study conducted by Dr. Cutney found that the lumacaftor ivacaftor use was associated with reduced levels of hepatic steatosis, so pre and post modulator treatment. So now we're starting to see that there's some evidence regarding that there could be components of metabolic syndrome in the CF population now, but there's still very preliminary evidence and unclear evidence regarding lipid fat, hepatic steatosis, as well as lipid levels. So that's what our study wanted to investigate further. So we're comparing lung function, body mass index, MRI proton density fat fraction, which is a very excellent measure at looking at the hepatic steatosis in the liver, and serum lipids under different modulator conditions. For our methods, we looked at a total of 30 adults from the UH hospitals with CF and that had an abdominal MRI performed under varying modulator status to assess PDFF. And the MRI was done on various conditions. So how we grouped them is that patients who had no modulator treatment at all, and then we had a group that had not highly effective modulator treatment. So in that group, we had the tezacaftor ivacaftor and the lumacaftor ivacaftor, and then we had highly effective modulator treatment, which we counted as ETI, and then we looked as patients progressed through different modulator treatment. For our criteria, we used a retrospective chart review. We assessed BMI and lung function within 3 months of each MRI. And then for the clinically drawn serum lipids, we recorded them if they were in 1 year time period from the MRI during the same modulator status. And when we were grouping the subjects for analysis, we had one group that had none or the non-highly effective modulator, so Luma-IVA, or the TEZ-IVA versus ETI, and then we had no CFTR modulator versus any CFTR modulator. It didn't just have to include ETI, it could also include the Luma-IVA or the TEZ-IVA as well. And then for our analysis, we used a paired Wilcoxon test to compare the pre and post-treatment data. So now getting to our results. We had 8 patients that had data available before and after highly effective modulator treatment. So like I described before, none or non-highly effective modulator versus ETI. And then we had 8 patients that had data available on no modulator versus any modulator treatment. So no CFTR modulator versus any CFTR modulator. So now looking at the data before and after ETI, we can see that there's a statistically significant increase in the ppFEV1, the BMI, the LDL, and the HDL before and after ETI. And you can see all the trends in these graphs here that are looking at the BMI, LDL, and HDL. We unfortunately did not see any change in the statistically significant change in the PDFF. It could be due to the fact that only 6 of the 8 patients in that group had the abdominal MRI available for us to analyze. There could be multiple reasons why, but we did not see that with this study. And we also did not see a statistically significant change in the triglycerides as well. So now looking at no modulator versus any modulator treatment, we were able to see a statistically significant increase in the BMI. And then we were able to see close approaching statistical significance in the HDL. It was at 0.06, so not at our alpha value at 0.05. But just keep in mind also that we only had 6 out of those 8 patients that had data available for the PDFF, LDL, and HDL per our inclusion criteria. And that's just describing the PDFF more. You can see that there's like one outlier that had like a really great decrease after no modulator versus any modulator treatment. So the strengths of our study, as I mentioned before, we utilize MRI PDFF, which is a very reliable measure of hepatic steatosis. So that was a really good strength and strengthened our study greatly. And then we also had longitudinal data. We were looking at these patients pre-Trikafta, pre-ETI time, where we were able to see them as they changed modulator status, which I think was a really big strength of our study. For limitations, unfortunately, we did have a very small sample size. We started with 30 and ended with 8 and 8 in each group, and we unfortunately couldn't find like all the data to be able to fully analyze it for those 8 and 8, which is why we couldn't use all 30 of them. And that leads me into my next point, that we were limited by the number of patients that got the pre and post lipid studies, because not all patients were getting regular lipid studies. It was more provider dependent. So we weren't able to have the full LDL, HDL levels to fully analyze data. So overall conclusions and take-home points. So treatment with the highly effective CFTR modulator, ETI, was associated with an increase in ppFEV1, BMI, HDL, and LDL, despite having a small sample. And in contrast to our prior study that was done at UH, which showed lower PDFF in patients treated with Luma and IVA, the PDFF did not change significantly as patients transitioned between their different modulator status. And then our main point, important to monitor the cardiometabolic risk factors in CF patients on modulator treatment. So now that we're in a different generation with modulator treatment, we really don't know the consequences of what we had started with the high-fat, high-legacy diet. If we are continuing to increase BMI, what could be the effect of having those increased cholesterol levels, and if there's an association with cardiac disease, and if we need to get lipid guidelines. I think there's still a lot of research that needs to be done on that, and if a further discussion whether we need to establish lipid guidelines, but I definitely think more longitudinal and multi-center studies need to be performed. And does anyone have any questions?
Great job.
One of the questions is, in your research, was there a screening tool used in the CF population to help detect early stages of liver disease?
No, we did not look at that in our study specifically.
And then with your outlier that you had pointed out, was your outlier no modulator to ETI? Is that the question? Okay.
I'm not specifically sure about that. I don't think we had that data recorded down, but that could be a general hypothesis because of such the decrease in the protein density fat fraction. None to them. Mm-hmm. Mm-hmm.
Sorry, this app is very challenging
No,
to look
okay.
through questions. No way to organize them. That's a really interesting study, and as someone who's a clinician, I'm always thinking, how would I apply this to clinical practice or findings? And I recognize the sample is small, but what do you take away from this that's most clinically relevant?
Yeah, so definitely what our study showed is that we need to start at least considering that there could be cardiac risk in CF populations. I don't think our study completely defines that because it's not a robust study, it's not multi-center, and it's not a very large sample size, but I think it furthers us to look more into that and maybe should we be checking lipid levels more regularly in this population. So I think those are just some thoughts to keep in the back of our mind. I think we've barely scraped the surface in that, and there just needs to be more research and studies done to evaluate that further.
Absolutely. I think that's a great point. And I think there are some centers that have added lipid panels to their annual labs to start following that more closely, particularly in the adult centers. So I think it'll be interesting to see how this area of cardiac risk and CF evolves in the setting of highly effective modulators. I appreciate that your study highlighted that.
Thank you.
Do you have any more?
Yeah, there's one. Did you see LDL levels increase beyond the normal range post-modulator therapy?
No, the LDL levels were still in the normal range. We just saw increases in them, and I guess thinking about that from this study, if we keep on looking increases years later, they could eventually go above the normal level, but our study did not see that specifically.
Any others? Oh, wait. No. I think that's all the questions we have for now, but you guys please continue to put them into the app as we go on. And thank you so much for your presentation and your time. It was excellent.
Thank you.
Okay. It is my great pleasure to introduce our final speaker, Erin Scalorn. Erin is a pediatric registered dietitian and certified diabetes care and education specialist with 18 years of experience. She works at McLean Children's with patients that have endocrine conditions, eating disorders, and cystic fibrosis. Erin is a trauma-informed provider that practices from a weight-inclusive and non-diet approach to health. Instead of focusing on weight and dieting, she works with patients and families to improve their eating competence and focuses on behaviors associated with health improvement regardless of socioeconomic status, gender, race, trauma, or weight status. Knowing that these factors are significant barriers that negatively impact health and health-related behaviors, Erin uses motivational interviewing and trauma-informed care to help support patients and families while making sustainable behavior changes to live healthy and active lives. She's going to be giving a presentation called Weight is the Matter. Welcome, Erin. We look forward to hearing from you.
Good morning. Whew. It's cold in here, right? I am so excited to be here presenting with y'all today. Okay, what do you push?
You have to press it kind of hard.
Okay. All right. I don't have any disclosures. So looking at my objectives, our lovely moderators gave me a wonderful list of things. As we go through these today, I promise you're gonna feel like I don't have enough information about what you're talking about. And I understand, because each one of these topics have almost been individual trainings that I've attended for like days at a time. So I apologize for the brevity, but if these are new topics to anyone, I'm excited to expose you. So one thing to note, I'll use weight inclusive care or weight neutral care. So some of the studies will say weight inclusive, some of the studies will say weight neutral. We're going to talk about bias and stigma related to weight. We're going to briefly discuss body image. I know there's been a lot of talks, at least in the nutrition sessions, about body image, and that, again, that's a whole training in and of itself. If anybody has not done PEP, I want to officially do a plug. I did my PEP training here. We're actually going to employ the art loops with some of the, yay, okay. It's a really great program. And then lastly, we're going to discuss joyful movement. So first, let's talk about the elephant in the room. Who enjoys talking about their weight and BMI? Hands? Anybody? No? Okay. I don't feel like I need to spend a lot of time talking about how this is a really, really sensitive topic and how for our patients from the beginning of their lives, for the pediatric patients that I've seen, all their parents and all they have ever heard is a comparison on where they are and where their BMI should be, which for those that matched up perfectly, awesome, no problem. But if you fell short, that's where the problem occurred. And it's not a lack of effort on our patients or our parents' parts, right? I want to preface this talk by saying basically none of my content is CF specific, okay? Referencing Juliana's article, we just don't have a lot of information, especially related to like the clinical outcomes of the changing in weight. I really loved the first talk and how it talked about, you know, they may just be going to where they would have been normally. And bodies are naturally diverse. And I think that's the best thing about human beings. We're not all the same. So, weight inclusive care assumes that everybody is capable of pursuing health and well-being independent of weight when given access to non-stigmatizing care. It challenges the assumption that BMI is a determinant of health. I honestly wish I could take like all the conversations we've had about BMI and bring it back, because this is the most I've heard about people talking about how crappy the BMI is. Now, if you are Belgian or male, it probably works great for you. But beyond that, it is not a great tool for the patients that we are seeing. It acknowledges that weight is not a behavior, it's an outcome. And I know this parentheses is probably a really hard one. Like, we want to believe that when we eat a certain number of calories and move a certain amount and get our heart rate up at a certain place, that our weight will do exactly what we want it to. Okay, I see lots of heads shaking, so yes, we all recognize we cannot implicitly control this. It accepts and respects the inherent diversity of body shapes and sizes and rejects the idealizing or pathologizing of specific weights. So you may find if I have to reference something like obesity or overweight, I will use quotes because we're not pathologizing that body size. I did want to include this slide. It's from 2018. So what we're seeing here is the top portion separated by men and women, and then at the bottom, age. And what we see is equal mortality risk at a wide range of BMI levels. Essentially, it's equal between about 17 to 18 and 33 to 34. And again, I want you to remember that this is not CF specific, okay? Switching gears to our weight-inclusive practices, we don't assume that everyone is healthy at every size, okay? If you've heard about health at every size, we're not talking about that today, but it drives me crazy when people say healthy at every size. I cannot look at a person and assess how healthy they are from the outside. What inclusive practice does do is invite curiosity, open-mindedness, and acceptance, which I know the providers that work in CF are so excellent at. It is not anti-weight loss, but it is against prescribing weight loss for improved health. If we look at the weight-centric care model, what we see overwhelmingly in research is it's unsustainable. If you look at a study, how many of them looking at weight loss go out beyond 6 months or a year? Not many. Or what's the attrition rate? It's really, really high. It lacks a focus on behaviors. So looking at eating patterns or movement or sleep. It also increases weight stigma and body shame, negatively impacts psychological and physiological health, and leads to the weight loss futile cycle. So this is the cycle. I'll let you look over it, but anyone who has pursued any kind of weight loss has probably experienced this to some degree. In contrast, when we look at weight-inclusive care, we see decreases in body weight and shame. It improves adherence to our health behavior recommendations because it is behavior focused. We can't guarantee a change in weight, but we can encourage the efforts you're putting in to movement or eating patterns. It improves access to care. I was astonished. We were sitting at dinner and one of the reps was sitting with us, and he's not a big guy, but he was talking about how he was delaying his medical checkups because he didn't want to hear the doctor lecture him about his weight. And I said, "Did you ever share that with your doctor?" He said, "No." And I was like, "You probably should, because I don't think that's their intention." And that's the hard thing. As I share this information, we're all on the same page. We are all trying to help. I know we may be on very different sides of the aisle on this topic, but our goal is always patient care and ultimately equalizing care for all bodies and all sizes. So if we're looking at obesity treatment here, you will see the weight inclusive or weight neutral approach to your left, okay? And that process that we see, whereas the weight centric or weight normative approach leads to that futile cycle and actually weight cycling, which today I don't have time to get into the details of how negative weight cycling is on your health, but that's more concerning than BMI. So barriers. What barriers do we have to weight inclusive care? I would say my whole medical training, like as a dietitian, I had all weight normative, weight centric care. I don't know about you guys. One of the big ones is bias. So bias is prejudice in favor or against one thing, person, or group compared to another in a way that's unfair. So specifically when we're looking at weight, we have negative attitudes, beliefs, judgments, stereotypes, discriminatory acts aimed simply because of a person's weight. And I want to shift there because if that didn't say weight, if that said race, if that said gender, right, we would be up in arms. None of those are acceptable, but I would say that weight bias is one of the last socially acceptable biases that exists. So let's practice right here. You have Steve. Steve is a 59-year-old male with hypertension and elevated lipids. So I want you to just think for a second. Steve's your patient, whether you're a nurse, whether you're a dietitian. What kind of recommendations would you want to give Steve? Just think about that for a second. So now we have Bob. Bob is also your patient, and he is a 55-year-old male with the same conditions. What recommendations would you give him? Anyone want to do a show of hands? Would your recommendations be different? Yeah, honest hands, for sure. Absolutely. Before I knew about what I'm talking about, absolutely. But here's the interesting thing. So if I tell Bob, lose weight, and that's all I told him, maybe I said exercise, maybe I said eat more fruits and vegetables, but my main take-home message was lose weight, okay? And he goes home. Versus Steve, I'm giving him more details about lowering his sodium. I'm asking him, what his diet composition is and his activity and all of those kinds of things. And so he goes home with a whole different set of recommendations. Now we look at those outcomes and we say, man, Bob is doing awful. It is because he is obese. We've provided different treatment to different patients. How would we expect the same outcome when we have different recommendations? If you're struck by this, I would really encourage you to take this survey. We all struggle with bias, no matter how hard we try. Every day I am learning, and so I hope you all accept this as just a loving reflection. It is in no way criticism or judgment. What does research tell us? So when we're walking into a room, this is what we're thinking about our patients in larger bodies. Take a look at that list. We cannot separate body size from a person's value or worth. Whether that's ourselves or walking into the room. Now think about trying to build trust and rapport with this patient coming in with that. What are they picking up from you? How interested are you in what they say? Moving on to stigma, it's a mark of disgrace associated with a particular circumstance, quality, or person. And of course, weight stigma would be that based on a person's weight, which again, we see social media makes things so challenging. I really like this study because we hear about the cost of obesity. But no one ever talks about the cost of weight bias, which brings me back to the dinner a couple of days ago where, the gentleman was sharing, he was delaying his appointments because of fear of weight bias and the weight stigma he would experience. And he wasn't even a very large man. Not that that is the important factor in here, but I'm just saying it is definitely a factor. When clinicians promote weight loss, they not only contribute to societal weight stigma, they may unintentionally set their patients up for lifelong weight cycling patterns. And I want to go back to my original statement that we are all trying to help. So many of us have been taught that the way to help is to tell people to lose weight. If we had a way to do that, maybe that would be good advice, but we know 60 to 95% of individuals who pursue weight loss will weigh the same or more in 5 years. Moving on to body image concerns. So people of all sizes struggle with body image. I don't know if anyone saw all the pushback from the newest Taylor Swift video that came out. She hopped on the scale and it said fat and everyone's like up in a roar. So a lot of people would hold Taylor Swift up as the ideal female form, right? And yet here she is on a national level sharing the struggles with body image. So self-worth and bodily appearance are highly connected. Poor body image can cause sufferers to feel like they are failing. When we look at body image and chronic illness, this is not CF specific, but children and adults report high rates of body dissatisfaction. And that's related to not only what their body looks like, but also what their bodies can do. Ultimately, how a person feels about their body impacts those health behaviors. We're going to get into that a little bit more, but I like to use the illustration if someone ever had like a pet that they didn't care for very much. Say you try to feed the dog and it's like snapping at your hand. How much time do you spend with that animal? Not very long, because you don't really like it. Whenever we're approaching health behaviors from that perspective, there's something wrong with me. I'm not good enough. I went to CF clinic. They showed me what my weight is doing. I got to fix this now because I'm wrong. How well is that going to help them long term? There are 4 aspects to body image, okay? We have perception, affect, cognition, and behavior. Again, there's a lot to all of this. The way we see ourselves, the way we feel about the way we look, the thoughts and beliefs we have about our body, the things that we do. There's so many individuals that will not do things because of how they feel about their bodies. For example, going on a beach vacation, right? If you're not happy about your body, then you're going to stay at home and miss out. And now you're saying all of this is happening because of my size. What influences body image? This is a cake with a whole lot of layers and a lot of isms, but safe to say there's a lot of things that influence each and every one of our body image and each and every one of your patients' body image. So let's transition to trying to use some of this information using that ART loop we were talking about from PEP. So ART stands for ask, reflect and respond, and tell. So we ask open-ended questions to elicit information and gain perspective. We're going to respond with empathy and use reflective listening to ensure understanding, and then give information in small chunks. And really quick, as we were talking about body image and you saw all that list, we're not fixing anyone's body image, okay? We're allowing them a safe space to discuss their concerns without any sort of judgment. So what if my patient wants to lose weight, right? I've started Trikafta, I'm happy that I'm breathing better, I'm more active, but my clothes don't fit, people are making comments about me, we take pictures, and I don't like the way I look, I want to lose weight. It's really good to ask questions to understand what the root of that desire is first. One of my favorite questions is, what do you hope weight loss will do for you? The teens that I work with, some of them are like, I think I'll have more friends, right? Which for us sitting here in the room, we're like, it's not related. Of course, in art, that would not be our response, but many times a patient's desire to lose weight is rooted in something that isn't necessarily going to be solved with weight loss. Also having them imagine what their life would be or how it would be different if they were to lose weight. Those are ways to open up that conversation. When they respond, we're going to empathize. If you've done PEP, those pearls are what you're going to just toss in there, validating their concerns, validating their desire to lose weight, especially in a world where Taylor Swift feels fat. Okay, that's not a feeling. Where Taylor Swift says she's fat. So it makes sense. What could we tell our patients, okay? We can reframe. Now, the first one I know, one of our presenters said BMI, or I forget how it said, but basically not health. But I feel like on ETI, we are seeing markers of improved health and lung function and things if we separate body weight. And that's really what this whole talk is about, is separating health from body size, okay? So we can reframe it, that this is a sign that you are healthier. We have improved nutrition absorption. We can teach them about weight bias and stigma. We can talk about the components of body image, and we can explore which ones are impacting them the most. We can talk about the weight futile cycle. I probably wouldn't start there because it's like you burst somebody's balloon and they're like, well, what do I do? Because so many of us don't know what to do if we're not dieting. And then talk about the benefit of health-related behaviors independent of weight change. So moving on to joyful movement, we want movement to be intrinsic. Babies are born loving their bodies. They're going to move. You set them down on the floor, they're going to start rolling. As soon as they can start to army crawl, right, they're going to get moving. We also want there to be a cultivation of play. I don't know if anybody else loves Brené Brown, but doing things just because they're fun, not because they'll help us achieve a goal, is vital to human development. Joy and passion are the strongest driving forces to physical activity. I really like this side by side because we think all movement or all exercise should be healthy, right? Working in an eating disorder clinic, I can very firmly tell you no. There is movement that is unhealthy, right? If we're rigid, we have to. It's unenjoyable. It's excessive. I can't go out with my friends because I need to exercise, right? That is not healthy activity. What does joyful movement look like? Moving because it feels good. Validating all types of movement. There are people who may not feel comfortable in a gym because as soon as they walk in, they're getting a lot of attention. Oh, way to go. You can lose that weight. Or, hey, fatty, why are you here, right? Sorry to use, that language, but that's what our patients face as you're talking to them about going to the gym and working out. They're going to have to bolster themselves up to fend off those comments. Reject the burn it to earn it mentality that very easily sets us up for some exercise bulimia, people tracking calories, how much went in and how much came out. Choosing movement that is enjoyable and tuning in to body's needs. I don't know about you guys, after 2 days of this, I can feel my body needs something else. Last night I was like, I want to do some yoga. And I'm like, no, bed. Right? And that's okay, because if I was like, well, I'm concerned about my weight or this or that, that's how we then slip into that unhealthy mindset. And the last one is, would you have heard this message any differently if I was in a different body? That's the question I'd leave you with.
Thank you, Erin. That was a wonderful presentation. We have a couple of questions,
Yes.
so if you'll hang out and answer a few. Oh, I just lost it. Dang it.
I'm gonna grab some water while you're looking.
Sure. Oh, where did it go? Oh, here we go. When discussing health and weight with patients, it's normally not a quick conversation, especially when using behavior change strategies in a busy clinic setting. Do you have any advice on how we can have these conversations in an efficient and an effective manner? Eternal question.
It is. Well, and again, I would encourage you to do the PEP training. So many of us are fixers. So the idea that you are going to go in and fix them or fix this issue for them, no one outside of them can fix. And I guess part of this is they're not broken in the first place in this perspective. Does that make sense? So I think making a safe space to talk about it and build that relationship, that's probably not a super popular answer because us dietitians, we want, the flow sheet that tells you the questions, and then if you answer, follow the numbers. And this is messy and hard, and cultivating a relationship where maybe you talk outside of clinic, or if you feel really out of your depth, if you have a mental health professional that is familiar with eating disorders and different things to facilitate that conversation. But you never fail with empathy, even if you don't provide any other information, you are doing your job. Can I actually give an example really quick that has nothing? So I had a patient with type 1 diabetes who was diagnosed, and his parents were on him. He wore a CGM. The alarm was set at, I think, 150, which is very, very, very low. And his parents were on him so much that he just stopped eating. And so even after he started insulin therapy, he was dropping weight like crazy. And so we had a visit, and basically all I did was listen and respond how hard it was. And I got an email a week later, and they're like, "Thank you so much for helping us. He's eating now." And I'm like, I did nothing. Nothing. It blew me away. I reached out to my supervisor. I'm like, "Help, I don't know what to do." And then when we got to supervision, she was like, "Oh, how's that going?" And I'm like, they're good. I didn't fix it, but it's good.
That's a great example, and thanks for sharing that.
Your talk was excellent. Thank you so much. There's a lot of questions and comments coming in from various folks about how do you incorporate this with your entire team of providers and other multidisciplinary members who may not have the same mindset, and how do you help to shift that for them when perhaps the provider has just come out of a room telling a patient just what you said, just you have to lose weight, and then you go in. How do you help that?
Michelle. I go back to the idea that we are all here to help. The doctor who just walked out of that room was trying to help. Sometimes I have to do, I'd say, a little damage control. In CF, I don't have this problem at all, actually. It's other clinics that I work in that are more challenging. Obviously, you want to support and reinforce what the doctor said. I think you can still focus on behaviors. I don't know if you've ever tried to do a counseling session without talking about weight at all. I would challenge you to, because it's really awesome. I feel like all we were taught as dietitians was teach people to lose weight, and that's sad if we have this much education and that's all we can do. Sorry. So you can go in and talk about a lot of the behaviors with them without really mentioning the weight. I mean, if I had someone who was in a small body, I'm asking them what they're eating, how they're sleeping, how they're moving. If I have someone in an average body, I'm asking them to say questions. Someone in a larger body, we're all human beings. We all need those things. Then outside of the room with the provider, I would try to begin to have a conversation maybe about my observations with the patients and maybe some of the things that they're doing. So for example, if a patient's really concerned about their weight and so they're starting to skip meals, you could say, I understand, this is our focus. We want them to be healthy, which they really mean lose weight, but anyway. But I'm seeing unhealthy patterns that are developing. Do you feel like maybe you could leave like weight and health behavior conversations to me, and let me see how we can kind of navigate that. That's what I would do. I don't know if it's right or wrong.
That's a great answer. I'm going to sort of combine two questions that were similar but very important. How do you get other team members on board for a more weight-neutral approach, both with direct patient care and also outside the room in team-only discussions like rounds? And how do we get other team members on board with this shift and sort of moving away from the old-school CF mindset of this constant weight focus?
I don't know, but if someone has an answer, can you teach us all? No. It's so hard. Again, I just go back to we're all trying to help, and it's the way we think we're helping people is tell them to lose weight. And it'd be like someone telling you the sky is green, all of a sudden you're like, no, it's not, it's blue. Like what? It's a whole new world. It causes us to feel off kilter, and I don't know about nurses, but dietitians, we don't like change. We like things that are old and familiar, and I was taught it, right? Whenever there's a change, we have to have a support group. So it can be really hard when you have like specific patients that maybe you see them develop eating disorder symptoms, and maybe there's an opportunity where the doctor's like, well, I don't understand, why did that happen? Da, da, da. Like that's an opportunity to plant a seed, to kind of reveal, well, maybe this could be part of it, maybe this could be part of it. What if we tried that? I have several of my doctors that I've brought along. Most of my work is in endocrinology. So about half of my providers are on board with a weight neutral approach. But then I have other ones that we agree to disagree, and I respect them fully. They're trying, again, it's all about helping patients, and I guess what help looks like.
Another great answer. So from all the trainings you've done, what have you found the most helpful for being a weight-inclusive and trauma-informed dietitian, or what would be good for other care team disciplines like nurses and physical therapists or even our research coordinators? Because I think this is something that every care team discipline, including the physicians, probably deal with.
Yeah, I would love to see trauma-informed care. I know the Birth to 5 short course was talking about ACEs. If you don't know what ACEs are, it's, oh goodness, now I'm not going to know the name. Something, acute childhood, adverse childhood, yeah. So trauma-informed is great. I did Fiona Sutherland, she's a dietitian. I did her training. That was the triangle that showed what all impacted body image. But there are a lot of resources out there. To name off ones for physicians or nurses, I don't know because I'm not one of those disciplines, but I would point you towards Fiona Sutherland. If you're a dietitian as well, there's Weight Inclusive Nutrition and Dietetics group, Heather Kaplan. Great resources. Actually, part of my slides came from something that you can download yourself from RD to RD. But there's tons of stuff out there, and it's so empowering to be able to have conversations beyond weight and to encourage continued health behaviors even when they're not seeing weight loss. That's been the biggest asset that I have seen in my practice.
Thank you so much, Erin. We have a little bit of time left. Here, go ahead. Here, Erin. We have a lot of questions and a little bit of time left, so if the rest of you are okay, we might select one or two to sort of go down and let you answer as a panel, if that's okay. If folks want to stick around, no pressure. Go through it. Where's that question? So the question that I wanted to ask all of you, or I was interested in asking all of you, is unfortunately BMI is still used as a benchmark for the CFF, so how can we change this?
Do you want to come up to use a
You can come up to the mic since we're recording, or I can try to bring this one down to you. Oh, look, I'm going to bring it down like the Price is Right. Hold on. Yeah. Sorry, I'm just trying to fill the time.
Just repeat that again.
Come up here, tall people.
So the question was, with BMI is still used as the benchmark for CF care, how do we help to shift that mindset into using something different or change? How do we get from where we have been to where we all feel like we want to go?
I mean, whoa. Okay, I'm already loud, so I guess I don't need to stuff the microphone in my face. How I would answer that is, I guess the mask doesn't muffle me very much, but is that the problem is that we use BMI because it's easy. That's the problem. So it's going to be very challenging to find something that is not labor intensive, although you are very close, so you should probably answer this. You should probably answer it first. But I mean, the main problem with BMI is that it's the reason we use it is because it's easy. That's really true. It's easy to track. You don't have to do anything at the visit to have it, because everybody's going to wait. We're going to wait and hype people. So you don't have to gather extra information at the visit, and I think that's going to be the trick. I don't think we're ever going to be able to get rid of BMI completely, because anything else is going to require us to be more proactive, unfortunately. You're better than me, though.
No. I mean, I think it's exactly as you said. It's easy. It's what we know. And when we don't know something, I mean, my small question was about mid-upper arm circumference, but I don't know a lot about it, and a lot of us don't. So unless we work with it more, or in the previous sessions when they talked about BIA or hand grip strength, unless all of us are practicing this and doing this, I don't think we can replace it, but I think we can shift away in the sense, like, as our last presenter talked about, the weight neutral approach. And I think that's the way of going at it, because with the HEMT, we know that I think, can uncouple the two. We don't have to focus on BMI, but we need to focus on the whole nutrition and the nutrition-focused physical exam, possibly.
Well, I think we've lost a lot of our audience, but I wanted to I wanted to thank our speakers. This was a wonderful and informative session. Thank you for staying behind to do extra questions. If you all want to keep putting questions in the chat, I think you'll be able to see the extra questions and you can respond to people in there. Okay? Thank you all for your time.